Yeah.
I feel very tired.
Yeah.
Could that be a thyroid problem?
It could be, but as I said to you, equally it may be something completely different. Most of us are trying to do too much. And I'm getting a bit sexist here, but most women are certainly trying to do too much. Working, running the home, doing everything they're being expected to do, and you can't manage it all. So no wonder you're tired. So it could be a thyroid problem, but often isn't. Easy done by the blood test.
I got thyroid, but I haven't got enough because my doctor in my blood coming.
Yeah. Yeah. So you take thyroxine, do you?
Yes.
Yeah.
I please take tablets for this.
Yeah. Is that thyroxine? You've got your glasses on. Yeah. I'll come on to explain all about that in a minute. Right? So that's a single lump. What happens with what we call a real goiter, an enlarged thyroid? Terrible term, but that's just the way we do. Now, as I said, in days gone by, the commonest cause was a lack of iodine. Now that's very rare, and we actually don't know the causes of most goiters. They are commoner in families, they are commoner in women. They actually, as the Wickham survey, remember that little survey in Newcastle, when they went back 20 years later, they found that quite a few people, the thyroid has got smaller. So they're commoner in earlier life and actually tend to get a bit smaller in later life. And we don't know what causes them. In the same way we don't really know what causes lumpiness in the breast. There are presumably signals going to the thyroid for it to get bigger. The majority of people with a goiter, just an enlarged thyroid, have normal thyroid function. You can get conditions when the thyroid becomes underactive, and that will cause an enlargement of the thyroid. But actually that's quite rare. So most people going with what we call a multinodular, multiple little nodules in the thyroid, have normal thyroid function. And then the question is, what do you do about it? The chances of it being anything other than benign are even less, but you can never be sure, so we do often put a little needle in just to make sure that's okay. And then there are a number of options. In years gone by, we actually used to try giving people thyroxine for that, but that really treated the doctor more than it treated the patient. It made us feel that we were doing something, but actually didn't do anything in the long run. And the thyroids didn't get any smaller than they would have done on their own regard. So for most people, if it's not bothering them, and so they're not getting any symptoms from it, then it can be left well alone and just monitored to make sure it's not getting any bigger or not malfunctioning. If it is getting bigger, then it can cause some problems. It can cause difficulties with the windpipe, so some people may have difficulties breathing. It can cause a blockage in the gullet, and what can be a particular problem is that it normally, as I said, sits above the breastbone, but if it pops in behind the breastbone, what we call a retrosternal thyroid, so it's going behind your sternum, then it's abutting onto lots of the other main blood vessels, organs, windpipe, gullet, and there's less room down there. In fact, it's remarkable if you look at scans, what will happen, and it will shift things left, right, and centre, and very often doesn't cause a problem, but it can do. And when it's below the breastbone, sometimes position can be a problem, that if you're in the wrong position, it can press against it and cause more symptoms. So if people are getting symptoms from it, then there are really only two options. One is an operation, just to remove it. The other, which we use more frequently now, is radioiodine. You remembered I said that that's what we did with the thyroid cancer. We also can use it for an enlarged thyroid because it will make the gland go smaller. The problem is it's not guaranteed how much smaller, and it's not guaranteed how quickly it will work. So if you've got severe symptoms, you are better off having an operation. But if the symptoms are not too bad, then radioiodine very often will bide some time or maybe even prevent a problem in the future. So we are tending to use that a lot more frequently than we used to, and operating a lot less frequently on thyroids. Because it's an operation, it's a safe operation in careful hands, But it is an operation, and we don't want to do that unnecessarily. And in fact, the lumps can come back, I regret to say. Over time, there is a risk, about 10 to 15%, the thyroid will grow back again, but not usually over a 10 or 20-year period. So if people have got real symptoms, then it's a very sensible thing to do, is to have the operation. But not if you're not getting symptoms.
What is the side effects for this tablet?
I'll come on to those in a minute. So that is lumpy thyroids. Now what about malfunctioning thyroids? The first is if the thyroid is overactive, what we call thyrotoxicosis or hyperthyroidism. Anyone in the room had this? Lucky you. It's still quite common, the symptoms, the thyroid affects throughout the body, so virtually every area can be affected if the thyroid is overactive. The commonest symptoms is that people feel hungry but lose weight because the metabolism is working faster. So they're actually burning up all those calories. So they're losing weight, but they're eating more. They feel the heat. So they're constantly turning down the central heating, and their family are getting particularly upset as they're getting freezing cold, while the individual is saying that it's all too hot. It affects the heart, causes a faster pulse rate, can cause irregular heartbeat, palpitations. And it can affect the bowels, so you get diarrhea, more frequent bowel movements. It can affect the skin and give you skin rashes and itching. It can affect the hair, you get hair loss. And it can affect your periods. Curiously, it sort of makes your periods lighter, makes you less likely to have periods and can make them lighter and can be associated with infertility. Those are the commonest symptoms. And it's diagnosed very easily by just doing a blood test, which shows that the thyroid hormone levels are high and the pituitary is recognizing that. So the pituitary hormone, the TSH level, is very low. And that means you have an overactive thyroid. The treatment, firstly, it can get better on its own in a few cases. You may just get an inflammation of the thyroid, what we call a thyroiditis, which will usually settle down within a few weeks. It can be quite an unpleasant illness, but often will settle down and doesn't necessarily need the thyroid to be treated. The commonest causes are, and overall the commonest cause, is what we call autoimmune thyroid disease, often called Graves' disease. And what happens there is, for reasons that are not clear, there are genetic factors, but the body produces proteins called antibodies which stimulate the thyroid to produce more thyroxine. So whatever reason these proteins are produced, they stimulate the thyroid to produce more thyroxine than we need, and you have an overactive thyroid gland. The other possible cause is if you do have a lumpy thyroid, that one of those lumps just sort of declares UDI and produces more thyroxine than it should. And that's called a toxic nodular goiter. So the first thing is to get it picked up, because quite often people have symptoms, but they either don't go to the doctor or the doctor's missed it or whatever. To get a blood test. But if you've got those classic symptoms, it'll usually be picked up pretty quickly. We can control the thyroid with medication quite easily and quite effectively and very safely. That you take medication, the commonest tablet that we use in this country is called carbimazole. And that goes into the thyroid and just stops it producing thyroxine. So you use a big dose, a big-ish dose at the beginning, get it under control, and then you can reduce the dose over time. And it's usually well tolerated and will control the thyroid as long as you take it. The fascinating thing about thyroid disease, from my point of view, and I've been at it now for 30 years, is that we still don't know how to do it. You still cannot predict what's going to happen. And people have spent their whole academic lives trying to prove, well, is one dose better than another? If you give it this way as opposed to that way, does it depend on the size of the thyroid, the age of the patient, this, that, you name it? And really there's no way of telling. Some people respond well, some people don't respond very well. And although there are some clues, the higher your thyroid hormone levels, the less likely it is to respond. Nothing is absolute, and some people will respond very well, and even some people with relatively mild conditions, it can be quite difficult. And we don't like keeping people on tablets forevermore, so we usually use carbimazole just for a year or two, keep it under control. Then if it's going to come back again, we either need to do an operation or the radioiodine, the same treatments as before, which will stop the thyroid being overactive, and then you'll need to be on thyroxine. Now, thyroxine is a very safe, simple treatment. It is just replacing what the natural hormone would otherwise be doing. And so levothyroxine, which is you're on, is exactly the same as the thyroid hormone that is circulating around everyone else's bloodstream. And it has really no side effects at all as a drug. The only issue is to get the dose right, to make sure you're taking the right amount for you, and that does vary between individuals. So it's important that you start off on a smallish dose, and then by monitoring the thyroid, we can work out thyroid function, we can work out how much you should take. And most people are usually on around about 100 micrograms, which is a fairly standard dose. Less than that implies that the thyroid is still working pretty well. More than that, probably not terribly well. May I ask what dose? Do you know what dose you're on? How much you're taking? 150.
Yeah.
Well, that's pretty much replacing most of what your thyroid would otherwise be producing. And that's fine. And a blood test once a year will measure the hormone levels because they're natural, they were picked up exactly the same way in the laboratory, and in exactly the same way the pituitary would sense your tablet in the same way they would sense any other thyroid hormone. So the pituitary test, the TSH test, gives us a very accurate picture of whether you're on enough thyroxine or not. So it's a very easy thing to do. And you don't pay prescription charges anymore. So it can be quite good from that point of view. And a lot of people, I'd say about 2% of the population are on thyroxine. So it is common. You will see and hear people say they can't get on with thyroxine and they want to be on alternatives. Natural thyroxine, and there's a preparation called Armour, which a small minority of people wish to be on. We in the British Thyroid Association don't recommend this because this is a thyroid extract. It actually comes from animals, the thyroids of pigs usually, and sometimes other animals. And we don't really know how much thyroid hormone is in it. Although they talk about grains, they do not have it as accurately defined as 150 micrograms of levothyroxine will be the same today, next week, next month, next year. So you know that you will be taking exactly the same. If you're on 2 grains of Armour, that may not be the case. But that said, I'm a great believer in people should be doing what they want to do. We as doctors should be here to try and explain things as best we can, outline what treatment options there are, and ultimately, it is for individuals to choose what they want to do. So I have a small number of people who said, I really don't like thyroxine, I want to be on Armour, they go on to Armour,